Good morning, everybody. My name is Ayman El-Saeid, Professor of Cardiology, Tanta University. I would like to thank the Egyptian Society of Cardiology for the invitation for this elegant course. My talk today about the right-sided cardiac valves. The type of valve disease ranged from stenosis and incompetence. The stenosis usually due to commissural fusion and shortening of the valve. This will reflect on the behind chamber, will be dilated, hypertrophied, and make a pressure load on the behind chambers. The valve regurgitation it is a type of scarring or shortening of the leaflet due to thickening, calcifications with different pathology, and both chambers are dilated, the chamber beyond and the chamber in front. The right side cardiac valves are two: pulmonary valve, tricuspid valve, in addition to the fantastic Eustachian valve. I will start with pulmonary stenosis. The guideline is deficient in the assessment of valvular heart disease in general, and the last guidelines, 2017, will recommend the initial ECG for evaluation of patients with pulmonary stenosis as evidence C. Also, transthoracic echocardiography is recommended for initial evaluation of pulmonary stenosis in adolescents and young adults every 5 to 10 years in mild cases. Cardiac catheterization is indicated in severe cases or moderate cases, and in mild cases, in some mild cases, to re-evaluate the gradient across the pulmonary valve. The ECG is fantastic in evaluation of pulmonary stenosis. You can calculate the pressure, and which is very accurate. In mild stenosis, may be normal. In moderate stenosis, right axis deviation, R to S ratio in V1 is usually more than 4, and it wave changes in the pericardial leads as secondary changes to right ventricular hypertrophy. The axis may be over 110 in severe cases, and the B pulmonale may be increased due to the right atrial dilatation and hypertrophy. Estimation of RB pressure from ECG, I said just a second, it is fantastic. You can multiply the millimeter elevation or the millimeter in the V1, the positive R in V1, multiply it by 5, and you can get the gradient, which is very sensitive, like echo Doppler or like cardiac catheterization. This is an example of 20 millimeter tall R in V1 multiplied by 5, and the gradient was 100 millimeter mercury. X-ray also is valuable for evaluation. It is normal in some mild cases. The main pulmonary artery may be dilated, post-stenotic dilatation, especially in the doomed type of pulmonary stenosis, right atrial dilatation, and maybe oligemic lung, as the pulmonary vasculatures may be decreased flow and oligemic lung. This is an example of pulmonary stenosis. In the right atrium is dilated, loss of the waist of the heart due to dilated pulmonary artery, and the RV also is dilated. The two-dimensional echocardiography is very important for evaluation of the type of stenosis. Is it doomed? Is it dysplastic? Is it hourglass? Also to evaluate the size of the annulus, as we can select the balloon 1 to 1.2 or 1.5 more than the annulus diameter. In severe cases, you can see the septal fluttering and RV enlargement, also the post-stenotic dilatation. This is an example of evaluation of pulmonary valve and the post-stenotic dilatation in the left side of the slides. Also, the left pulmonary branch and the right pulmonary branch both are dilated. The color Doppler to evaluate the shape of the jet. Also, the continuous Doppler to evaluate the gradient across the valve. In subpulmonic stenosis, the jet tend to dagger-shaped and delayed peaking in systole. In valvular stenosis, the jet is central and cause gradient across the pulmonary valve at the site of the valve. Also, the echocardiography can be used for evaluation of pulmonary incompetence. The pulmonary incompetence is very important, and severe cases of pulmonary incompetence may necessitate to do surgical valvuloplasty rather than balloon pulmonary valvuloplasty. This is an example of valvular pulmonary stenosis, and this is the jet, and how to calculate the gradient across the valve. To assess the valve gradient, mild less than 36 mm mercury is the peak, moderate from 36 to 70 to 64 mm mercury, and severe above 64 mm mercury, and the critical stenosis more than 80 mm mercury. Other investigations, hemoglobin and hematocrit value, especially in cyanotic patients, may be variable. In mild stenosis, when the gradient less than 36 mm mercury, usually this gradient will not increase from the literature and from the meta-analysis of cases of pulmonary stenosis and the follow-up from 3 to 5 years. In moderate cases, when the gradient is more than 50 mm mercury, this is an indication for percutaneous balloon pulmonary valvuloplasty, and the limited cases for surgical valvuloplasty when the valve is dysplastic and post-stenotic narrowing rather than dilatation. This is an indication for surgical valvuloplasty. To care about the baby and to care about the saturation, this is not our issue. According to the guideline in 2017, you have to dilate the pulmonary valve when the gradient more than 50 mm mercury, or it is critical more than 80 mm mercury, and in mild cases you can follow up the patient. The dysplastic valve, which is a special type of the valve is thickening from the start and no post-stenotic dilatation. This is maybe dilated by oversized balloon or maybe need surgical valvuloplasty. The prophylaxis against infective endocarditis in high-risk patients, when the gradient is high, you can give bacterial endocarditis prophylaxis is recommended for cyanotic patients for 6 months post-operatively after transannular patch placement. You can monitor your patient and follow up by echo, by ECG, and by clinical assessment. Pulmonary stenosis in pregnancy, in mild cases, the pregnancy can tolerate the pulmonary stenosis. In moderate to severe cases, it also can tolerate, and if symptomatic, you can dilate the pulmonary valve in the second trimester, which is safe. Also, in presence of arrhythmia, you can control by antiarrhythmic treatment. Consideration for labor and delivery. Patients who are asymptomatic during pregnancy generally tolerate labor and delivery well. Antibiotic prophylaxis is not recommended for cesarean section and is considered optional in patients with pulmonary stenosis associated with complex congenital heart disease. In athletes, when the gradient less than 50 mm mercury can be tolerated and can be asymptomatic, and in severe cases it became symptomatic and necessitate to do balloon pulmonary valvuloplasty. This is the reference for my talk. The second lesion in the pulmonary valve is the pulmonary incompetence, which is sometimes neglected by cardiologist and echocardiographer, but it is very important. In adult, pathological pulmonary incompetence is consequence of prior intervention for congenital heart disease, such as phalangotetralogy, repair, and placement of outflow tract patch for surgical valvotomy for isolated dysplastic congenital pulmonary stenosis. Additional causes of pulmonary incompetence include rheumatic heart disease, carcinoid disease, trauma, endocarditis, and pulmonary artery and annular dilatation. Pulmonary incompetence can occur secondary to pulmonary hypertension. The diagnosis is well visualized by echocardiography, as the right side is anterior structure, so transthoracic echocardiography is enough to evaluate. Trivial or mild cases can be neglected, but moderate and severe cases can be evaluated by the wide hollow diastolic jet and the density of continuous wave Doppler, and can calculate the severity by deceleration time and pressure half time. Indication for intervention. Pure pulmonary incompetence usually not need to do any intervention. But if it's the course of followed of tetralogy after correction, or in the course of right-sided surgery, you can do pulmonary repair for pulmonary incompetence. So the indication for intervention: symptomatic related to pulmonary incompetence, presence of arrhythmias, RV dysfunction, which is progressive and continuous ejection fraction less than 40%, calculated by magnetic resonant imaging, progressive RV dilatation, moderate or worse tricuspid incompetence related to dilated annulus, severe pulmonary incompetence requiring another cardiac surgery, presence of arrhythmia due to RV overload. This is the indications for pulmonary repair. The second valve is the tricuspid valve, which is very important, tricuspid incompetence. And different etiology ranged from congenital anomalies like Epstein disease, tricuspid valve dysplasia, congenital tricuspid leaflet deformity, endocarditis, trauma, carcinoid disease, rheumatic heart disease, and the tricuspid valve prolapse. And the very important is the secondary causes of tricuspid incompetence due to pulmonary hypertension or due to left-sided heart lesions. This is an example, and in the right, the jet of tricuspid regurg. Sometimes it is blue and sometimes it is mosaic according to the mechanism of tricuspid incompetence. The management of tricuspid valve disease, especially incompetence, is very important, ranged from tricuspid valve repair to tricuspid valve replacement. And another issue is the percutaneous tricuspid valve replacement. The evaluation of tricuspid valve is very simple and easy and can be done by two-dimensional echocardiography. As I mentioned before, it is anterior structure and can be evaluated by the traditional or the conventional two-dimensional echocardiography from parasternal long axis view, parasternal short axis view, and some modified views. You can evaluate and you can visualize the tricuspid valve leaflets and apparatus and the chorda tendini and the biliary muscle. The three-dimensional echocardiography is very important for evaluation of the three leaflets: the anterolateral leaflet, septal leaflet, and the inferior or posterior leaflet can be visualized by two-dimensional echocardiography. So you can look into your own tricuspid valve three-leaflet cusp and subdivided and accessory commensals cusp. Anterior leaflet is generally the largest one, septal leaflet is generally the second one, and the posterior leaflet is the smallest one. The tricuspid valve function is very important and it is different for completely, not like the mitral valve. Coaptation of tricuspid valve leaflet is dynamic, complex process involving entire valve apparatus. Optimal coaptation occurs when the annulus has elliptical shape due to limited mobility of the septal leaflet, which is very short. This is maintained by atrial, annular, papillary muscles contractions. The tricuspid valve is not designed to close circulatory office. Circular geometry results in septal leaflet being pulled away from the anterior, posterior, or leaflet, resulting in valve incompetence. The 3D is important for evaluation of leaflet anatomy, identification of any cleft or indentation, and the location of the coaptation defect. The surgical repair is still challenging, still unsatisfactory, and still in need for re-evaluation. The initial consideration in surgical repair, prolonged clinical course, presence of symptom of reduced cardiac output, presence of secondary pulmonary artery pressure elevation, and evaluation by MRI, which is the gold standard for assessment of RV function. This is an example of three-dimensional echocardiography for evaluation of the leaflets, the anterior one, the septal one, and the posterior one. Tricuspid is different from mitral. It is not circular and has three leaflets, and the longest one is the lateral leaflet, and the evaluation is by transthoracic echocardiography. In the mitral, you can use the transesophageal echocardiography. Risk factor associated with high post-operative tricuspid regurg. Higher grade of preoperative tricuspid regurg will reflect on the result of tricuspid valve repair. the female is less in the prognosis. The lower left ventricular ejection fraction, the preoperative permanent pacemaker may be interfere with the proper tricuspid valve repair and the presence of coronary artery disease or large LV mass index. This is an example of anomalies of Epstein anomalies. And the secondary causes is very important. This may be pulmonary artery hypertension due to left side heart lesion, due to dilated cardiomyopathy, due to mitral valve lesion, and may be rheumatic Epstein degenerative carcinoid or endomyocardial fibrosis. Also, the trauma is very important in the tricuspid valve. It is an anterior structure and can be by blunt or sharp trauma can induce tricuspid regurgitation. Also, pacing and defibrillation lead may be induced tricuspid valve incompetence. The mechanism and evaluation, RV and annular dilatation, failure of coaptation, and the tethering mechanism. This is the three mechanisms of tricuspid valve incompetence. And if the valve with incompetence and the right ventricular dysfunction with dilatation and the pulmonary hypertension, this is an indication for tricuspid valve repair. The problem in the primary tricuspid valve lesion. This is an example of Carpentier ring and for tricuspid valve and repair, and the jet will be reduced. This is an example of carcinoid disease with both incompetence and dilatation of the tricuspid valve, and this is an example of evaluation of RV pressure by the gold standard of MRI or cardiac magnetic resonance evaluation of RV pressure. This is a pacemaker, permanent pacemaker with induced tricuspid incompetence, and this is the jet with tricuspid incompetence with the pacemaker. Very important to evaluate by three-dimensional echocardiography to visualize the septal leaflet, to visualize the inferior leaflet, and to visualize the anterior leaflet, and to know the mechanism of tricuspid valve regulation, which will be reflected on the way of repair. The jet in the secondary tricuspid valve incompetence usually eccentric jet towards the septal leaflet. This is not like the mitral. The jet in the functional mitral regurg will be central. Here will be toward the septal leaflet due to long anterior or anterolateral tricuspid leaflet. Of course, the evaluation of tricuspid incompetence will be by the jet area, and you can evaluate if the patient is mild or moderate or severe according to jet area, according to the vena contracta width, according to the PISA, more than 9 centimeters will be severe, or according to the hepatic vein flow and tricuspid inflow in the hepatic vein. This is an example to mild cases. Jet area less than 5 centimeter is mild. From 5 to 10 is moderate. More than 10 is severe. Also the vena contracta and PISA for evaluation. Also the hepatic vein flow is very interesting to know that the systolic dominant will be in mild cases and systolic blunting in moderate cases, and the severe cases you can see the systolic reversal flow in the hepatic vein flow. The annulus is very important. If the annulus is dilated more than 40 millimeter, it is a case of severe tricuspid valve incompetence. And you can know that there is a term of tricuspid annular shortening. If the difference between the systole and diastole in the tricuspid annulus is small, this is reduced tricuspid annular shortening, as this is indicator for severe tricuspid valve incompetence. How to measure the annular diameter, and how to evaluate before surgery for tricuspid annular shortening. The tethering distance is very important. In the left, this is the tethering distance. In the right, this is the tethering area covered between the two leaflets. And this is another mechanism for tricuspid valve incompetence. And this is evaluation of RV pressures by magnetic resonance. And how to evaluate in the modified view the tricuspid annular shortening and the less motion of tricuspid annulus, which indicate severe tricuspid valve incompetence. This is an example of three-dimensional, real-time three-dimensional echocardiography, full evaluation of different leaflets, the anterior one, septal one, and the posterior one, and the mechanism of tricuspid valve incompetence. In spite of advances in the management of tricuspid valve disease, still current questions, can real-time 3-dimensional echocardiography or CMR provide more accurate estimation of annular size? Can the new imaging modalities help to put a plan for surgery and improve outcome? Can new imaging technique more accurate to assess RV pressure, especially in presence of severe tricuspid valve incompetence? Should be monitor the patient for tricuspid valve progression? If so, which patients? Whose patient will be evaluated? And this is the last guidelines. You can do tricuspid valve repair in the course of mitral valve disease with presence of severe tricuspid valve incompetence, also in the primary tricuspid valve lesion. But in severe tricuspid valve lesions, who is symptomatic, it is better to start with medical treatment. No clear indications for isolated tricuspid valve lesion. If severe and symptomatic, and in spite of aggressive medical treatment, you can do tricuspid valve surgery. But from my experience, tricuspid valve lesion equal to diuretic therapy. This is a different approach. Recently, the percutaneous transcatheter valve implantation in the tricuspid valve, and this is a good trial and large study. Also, tricuspid valve stent implantation, novel stent with self-expandable, super absorbable polymer. This is accepted, and the result is accepted. And this is the details of the technique, and it is a simple technique. Also, this is percutaneous caval stent valve implantation investigation for an intervention approach for treatment of tricuspid incompetence. This is the technique. My take-home message for tricuspid valve disease: more than mild tricuspid should provoke a detailed assessment. Significant tricuspid regage lead to significant function impaired and reduced survival. Majority of tricuspid regage are secondary to pulmonary hypertension or RV disease. Echo and MRI both are important to assess the etiology, severity, and the mechanism of tricuspid valve incompetence. The tricuspid valve stenosis is a disease usually associated with mitral valve disease, like rheumatic heart disease. Different etiology may be congenital, may be right atrial tumors, carcinoid disease, valvular vegetations, and extra cardiac tumor may induce tricuspid stenosis. The usual symptom ranged from mild symptom, congestion, hepatic congestion, ascites or peripheral edema, to severe fatigue and GIT disturbance. It is different from mitral stenosis. Here, the mean gradient more than 5 millimeter mercury is a severe tricuspid stenosis. This is very important. Also, pressure half time equal to 190 millisecond. It is a severe tricuspid stenosis. In the mitral, the pressure half time was 200 millisecond. Here, 190 second is considered severe tricuspid stenosis. Also, the indications in tricuspid may be balloon in some rheumatic heart disease, and may be surgery if the patient is severe and symptomatic, or in the course of mitral valve disease surgery, you can do tricuspid valvotomy or tricuspid valve replacement. The last one is the right side cardiac valve, is the Eustachian valve. What is the Eustachian valve? It is the valve of inferior vena cava. It is a ridge variable thickening in the inferior of the right atrium. It is remnant of fetal structure that direct the blood in the fetal circulation from foramen ovale to the inferior vena cava, away from the right atrium and away from the tricuspid valve. What is the problem of Eustachian valve? If it is complete regression, it mimics the thrombus, so maybe thrombus and missed in diagnosis of right atrial thrombus. Also can interfere with placement of ASCD device in the course of closure of patent foramen ovale or ASCD closure. And this is example of Eustachian valve extended from the inferior vena cava to the interatrial septum, and this is normal, is present, and if it is persistent, it might mimic the thrombus, or it might interfere with implantation of device in the course of ASD closure or patent foramen ovale closure. I think this is the last slides, and I would like to thank you very much.